Welcome to GynoCurious, the show that explores what it means to be a healer and to be healed. Before I begin today's solo act, I want to announce a wonderful opportunity that I am just so excited about. On November 8th through 15, so again, November 8th through 15, I am thrilled to announce I am participating in an adventure to Iceland with Green Adventures, an amazing travel company that focuses on travel for women. This 8-day trip focuses on mindfulness, hot springs, and the menopause. Please go to Green Adventures, GreenEdventures, and look at this opportunity for you and perhaps your friends, your sisters, your cousins to take some time for yourself to heal and to learn more about the perimenopause and menopause with a small group of women while enjoying the northern lights, time away from your daily routine, and to travel with an expert company who provides everything you will need. So again, go to Green Adventures, GreenEdventures.com, or call 888-622-4911 for more information. Please join me on this great adventure. So I just returned from Long Beach, California, where I attended the International Society for the Study of Women's Sexual Health, or what's known as ISSWSH. It was their annual meeting, and I thought there would be no better time to do kind of a solo act on female sexual dysfunction. So for far too many women, when they go to the GYN or their primary care doctor for their pelvic exams, their pap smears and mammogram scripts, they rarely talk about sex, despite having a concern about their intimate lives. Studies have shown that the majority of physicians and clinicians also don't ask about sexual activity and sexual comfort with their patients. The World Health Organization defines sexual health as the following: a state of physical, emotional, mental, and social well-being in relationship to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. I love this definition. It's so global. It talks to so many aspects of our sexual experiences. For me, sexual health is part of our overall health, and I believe that discussions in the office setting should include not only ruling out any dysfunction, but speaking about pleasure and satisfaction as well. When was the last time you or your clinician have asked you, are you having sex or in an intimate relationship? And if so, are you having pleasure with these encounters? A striking 30 to 59% of adult women experience sexual dysfunction. There are so many barriers as to why sex is not discussed in the office setting. I've mentioned these before on GynoCurious, but I think it's worth re-mentioning. One, many clinicians have absolutely no training in sexual health and don't feel expert enough to speak about this matter. Others avoid speaking about sex due to time limitations and a concern that they will open the proverbial Pandora's box if they start a conversation about this topic, and not take care of what they perceive as more important for their patients in the limited 10 to 15-minute appointment. Also, clinicians are human, and some just can't talk about sex, much like their patients, either due to feelings they have no language to talk about it, barriers due to cultural taboos, and difficult personal histories with sex. Some clinicians also feel there are not enough resources to help women with sexual dysfunction, so they avoid this topic entirely. I respect these obstacles, but any clinicians who might be listening, you can use some validated questionnaires in the office to assist you in finding out about sexual function. Then either make an additional appointment to discuss or refer based on those results. But it's true, speaking to women about sexual dysfunction can take time, certainly takes attention and interest, and sometimes treatments can be really simple, and sometimes they demand a much more complex conversation with the patient. So often, sexual health is multifaceted. Clinicians and patients should consider the interplay between the physical, psychological, emotional, and sociocultural aspects of a woman's life. But treatments are available. So please, please, please find time if you're a clinician to ask these questions. And if you're a patient, please talk about them with your clinician. So there's lots of things that lead to sexual dysfunction. And for many people, there's more than one cause. Common causes for sexual dysfunction include things like stress, fear and anxiety about sex, alcohol, tobacco and drug use, hormone levels, mental health issues like depression and anxiety, sexual assault or trauma in your past, problems in your relationship. Even medications and treatments for chronic medical diseases can impact experiences in sexual health. The menopause. Have you recently been pregnant, giving birth, or breastfeeding? This can affect your sex life as well. And again, chronic medical problems like cancer, diabetes, heart problems, multiple sclerosis, or bladder problems can impact how you experience your intimate life. So ISSWSH defines female sexual dysfunction, or FSD, as chronic, distressing sexual symptoms related to desire, arousal, or orgasm, or persistent sexual pain that causes personal distress. These conditions generally last for a minimum of 6 months and occur in at least 75% of sexual experiences. So again, these key categories are called 1, hypoactive sexual desire disorder, or HSDD, and this is a lack of sexual desire or thoughts, or reduced interest or receptivity to sexual activity. The second category is female sexual arousal disorder, or FSAD, and this is difficulty attaining or maintaining mental excitement, what's called cognitive, or genital response, including lubrication and engorgement. And then there's female orgasmic disorder. This is the marked delay in frequency or absence of orgasm or reduced intensity. And the last category is genital pelvic pain or penetration disorder. And this is pain or fear of pain during vaginal intercourse or penetration. These problems can be lifelong or acquired, generalized or situational. So some folks will only have one issue going on and others might have multiple. Hypoactive sexual desire disorder is the most common female sexual health concern. It's defined again by a lack of motivation for sexual activity, manifested by decreased or absent spontaneous desire, decreased or absent responsive desire to erotic stimulation, or an inability to maintain desire through sexual activity. For many, many women, this is the greatest distress they have, particularly as they age. They want to feel sexual interest. They want to feel libidinous. They want to feel horny. And they describe the absence of these feelings and a great deal of distress about this. So HSDD affects about 9% of women between 18 and 44. So it's not just a manifestation of the perimenopause or menopause. 12% of women aged 45 to 64, and 7% for women older than age 65. This lack of desire may be long-standing, newly acquired, or even situational, with only one partner and not another. And science has demonstrated an association with the postmenopausal state, smoking, depression, obesity, and even educational level. There's also an association with androgens like testosterone as well. Female sexual arousal disorder can be manifested in the genital region or even cognitively. It's the distressing difficulty or inability to attain or maintain an adequate genital response, lubrication, genital engorgement, or genital sensitivity associated with sexual activity for at least 6 months. It can be a physical problem associated with vasculature or neurological problems. Or in contrast, female cognitive arousal disorder is the difficulty or inability to maintain mental excitement associated with engagement in sexual activity. And these causes can be hormonal, neurological, vascular, infectious, inflammatory, psychiatric, interpersonal, and even sociocultural. Female sexual dysfunction can also manifest as a disorder of orgasm, which is the persistent or recurrent compromise of orgasm frequency, intensity, timing, or pleasure associated with sex for at least 6 months. And this has to be distressing to the patient. There are many physical issues that may be the cause of this, and may even be a lack of appropriate stimulation. There are still women out there who believe that orgasm only happens with penile penetration, and in fact, most women need clitoral stimulation to have an orgasm. So again, it may be a way in which you're making love and not a problem with orgasm itself. And then there are the genital-pelvic pain disorders that contribute to sexual dysfunction, such as vulvodynia, vestibulodynia, the genitourinary syndrome of the menopause, or pelvic floor muscle dysfunction. So this is a lot of verbiage, and it's not always easy to talk about these issues because they're kind of complex, or maybe you're confused about what might not be going right. My counsel is, if you're not feeling like you're getting what you need in the bedroom and are distressed about it, please bring this up with your clinician. Have your clinician try to disentangle all of these diagnoses. You have to be brave, and you have to demand some attention about this aspect of your life. And if your GYN, primary care doctor, or urologist can't speak to you about this issue, please ask them to refer you to someone who is expert in the field of women's sexual health. There are sexual health clinics around the country, individuals doing this work, and even some telehealth companies who can assist you in this matter. I'd recommend that whomever you see, that a full history and physical be done to best understand and evaluate this sexual dysfunction. Problems caused by medications, interpersonal relationships, and psychological barriers must be ruled out. And if you have a history of abuse, often a therapist is the first person you might want to see in your healing journey. Treatments may be as simple as a good vaginal moisturizer or a lubricant. Some vaginal hormones, or even a pelvic physical therapist can be just so very helpful in interpreting the problem and giving advice. Products are out there for arousal and orgasm, and a discussion about interventions for low libido should be absolutely pursued. A good female sexual health clinician can help you better understand what might be preventing you from having a great sex life. This is an important aspect of your overall health, so please ask for help. Try to eradicate shame or embarrassment that might keep you from asking about this, and know that in the end, if treatments or interventions can assist you in having better intimacy with your partner, isn't that worth working towards? Thank you for joining me today on GynoCurious. Please share the show, rate the show, follow. And thank you to Jen Hammoud and Mazzy Rosenberg, my co-producers, and to David Hoffman, the editor of the show. Please, everyone listening out there, stay curious and stay well.